Today is a small talk, I won't say lecture or something like that, but on tongue. And it has tremendous importance in clinical medicine and also oral and also pediatric. Now, with tongue, you have to, you are big enough to know the uses of tongue. Your taste, your different activities, and also you can sing a tune with the help of your tongue. You can call your friend by whistling. And so with this introduction, I would like to tell you a small story. I think Monday I told in the practical class. In 1988, I was in Delhi for a first Asia-Pacific conference, and at 11 p.m. in Connaught Place, I would looking for a auto. But any auto, they are going to north or south, they are just saying, no, I won't go there. Then suddenly, what I did, I whistled. Now, the auto wala just put his hand and he stopped. He stopped. And he turned, I told him, Jamuna Park jayenge. That is in IMA guest house in, not Jamuna Park, in front of Delhi Police Headquarters. It's just hardly 2 kilometers or 3 kilometers from Connaught Place. Now you are shouting, your friend is going, you can just whistle. Okay, now you in the campus, you practice just to, in case of any, you want to call your friend, you can use this as a tool. Okay, now what I would say, now please, one thing I tell you, as you go to the dissection hall or today you have a spinal cord in histology revision. Now you can take the specimen from our people, you just ask them for the tongue specimen. So after the lecture, you go to histology lab, see the spinal cord, and then return to the demo room and see this tongue viscera. Okay? Now presenting parts of the tongue: apex, base, dorsal and inferior surface, 2 lateral margins, root. Apex in contact with incisor tooth, base directed towards oropharynx, connected to epiglottis by median and lateral glossio-epiglottic folds, vallicular, separate median from the lateral glosso-epiglottic fold. Now, see the tongue here, this is the larynx, the trachea, and this is the portion of the mandible. Now, this is a beautiful picture. Now, the dorsal surface, this is the dorsal surface, and this is foramen cecum. Dorsal surface is lined by non-keratinized stratified squamous epithelium. Presence of foramen cecum and sulcus terminalis. Presulcal part has papilla. Pre-sulcus parts have papilla, vallate papilla, fungiform papilla, vallate papilla, filiform papilla. Post-sulcus part is devoid of papillae and glands and lingual tonsils. Okay. Now you see, you can be asked a question, the dorsal surface of the, describe the dorsal surface of the tongue, or the tongue, you draw the dorsal surface of the tongue and label it. And the position of the papillae, the types of papillae, pre-sulcal part has papillae, vallate papillae, fungiform papillae, vallate papillae, filiform papillae. Post-sulcal part is devoid of papillae and glands and lingual tonsils. Now you can see the inferior surface. The inferior surface, mucous membrane devoid of papillae, presence of frenulum linguae, this is the frenulum, and sublingual papilla on the sides of the base of the frenulum. Plica fimbriae passes upwards and medially, and profunda linguae vein between the frenulum and plica. Now, if there is the frenulum is short from birth, the child, the mother, when she breastfeeds, she can feel it, the tongue suckling. Now, once it is 1 year or 2 years, the mother brings you to notice that the tongue doesn't protrude. Naturally, it is the condition known as tongue tie. Over here, and it is now this tongue tie has to be operated at the earliest. Previously, we general surgeons used to operate on it, but now it is in the domain of the dental surgeon. So if a patient comes to you in the outdoor, you recommend to visit the dentistry department. It is a simple operation for the tongue tie. I am exaggerating the tongue tie. Now, usually we do use Z-plasty, or if it is a small tongue tie, you can snip, and then if the child is 3 years old or 4 years old, you try to give him speech therapy. Speech therapy in the sense, mother will say and ask the child to protrude the tongue like goddess Kali. Hey, jeepta dekhao to, like goddess Kali. That's the best example of how to protrude the tongue. The image of goddess Kali will immediately come into the visualize, and hey, Kali ki dekhechiz, Ma Kali dekhechiz. But before operation, call Kali, Tali, Tali. Now, if the child is big, even 6 years, 7 years child, they bring to you. It's not the, most of the things that don't come into the notice. Many of the mothers are not so sensitive. Sensitive in the sense that they ignore it. They don't think of surgery. But today, in the days of modern anesthesia, you can perform anything. Okay? Now, this is a good illustration and a picture probably from netter, I think. Lateral margin covered with mucous membrane. Lateral margin covered with mucous membrane. Palatoglossous arch attached to the anterior 2/3 of the and posterior 1/3 of the tongue. Root extends from the symphysis menti to hyoid bone. And this is the hyoid bone. This is genohyoid muscle, this mylohyoid muscle is cut. The hypoglossal nerve, genioglossus muscle is cut. Lingual nerve and your hypoglossal nerve, this is submandibular duct. Here is the submandibular duct. This is the tongue. Okay, root extends from symphysis menti to hyoid bone formed by genioglossus, lower part. This is the genioglossus, lower part. Now, lateral margin root. Muscles of the tongue. Now, median fibrous septum attached to the hyoid bone through hyoglossal membrane divides tongue into symmetrical halves. Extrinsic muscles alter the position of the tongue. The genioglossus, hyoglossus, chondroglossus, styloglossus, palatoglossus. These are the extrinsic muscles which alter the tongue. All different types. You do this. Okay. You do this. You do this. You put it in the palate. This is controlled by the extrinsic muscles. Now, intrinsic muscle alters the shape. Intrinsic muscles alter the shape of the tongue. Superior longitudinal muscle, inferior longitudinal muscle, transverse lingually and verticillus lingually. Now you can see the muscles. This is the tongue. This is the mandible. Now we can see the mucous membrane removed. The palate. This is the uvula. This is the tongue. This is the mandible. The inside the tooth is here. Now, structures in relation to hyoglossous muscle. This is important. The structures in relation to hyoglossous muscle. Now, inferior longitudinal muscle, this is the lingual artery, see it's going like this. Now, this is the lingual nerve. This is genioglossus muscle cut off. The hypoglossal nerve, geniohyoid muscle, mylohyoid muscle. Now, submandibular duct is here and inferior longitudinal muscles here. The lingual artery, sublingual gland, hyoglossous anterior fibers, epiglottis, hyoid bone. This is the epiglottis, this triangular, this part. You can see when you take a tongue depressor, you just and make the patient open the mouth. You can see the uvula, you can see the epiglottis and the relation of the tongue. Because see, now, if there is any lesion, this is the teeth. Now, it can be that of repeated biting, the occlusion, there is some occlusion defect, gall cambrephala. You bite the buccal surface of the oral cavity. Cambrephala. Now repeated or some sharp, the broken tooth or that is constant in friction with this portion of the tongue might cause an ulcer. Don't take it lightly. The ulcer of the tongue should be brought into your notice. You take a small biopsy or you take a sphere first and do a stain, and also you refer to the dentist, because oral cancers, oral mucosal cancers are handled by the dentist. It is the oral pathologists who handle this. And if it all you have to go for surgery, it can be, they don't remove the tongue, they remove the tongue as a whole. It can be this portion, this portion can be removed, with leaving the portion which is healthy, and accordingly, and also when I show you lymphatic drainage, you can see that according to the submental lymph nodes and all these lymph nodes, you can take an FNAC of these nodes for the ulcer. And but repeat, if it is an inflammatory lesion with an ulcer, you train your hands, fingers. They are the best instruments. You palpate. Put your finger and feel, gentle touch, and see if the tongue is hard or rough. According to the condition, you plan. But it will be best that you examine the teeth even. This you must know. And the condition of the tongue, and there are many diseases like a typhoid tongue. In medicine, dekhi, like that. To see, or dehydrated, patient is dehydrated, acute diarrhea or something, dry. Immediately you have to give IV infusion and manage that case accordingly. Now, structures in relation with the hyoglossus muscle. This is the hypoglossal anterior fibers. This is a paratopharyngeal arch. The arterial supply of the tongue. It is very richly supplied. When you are taking some food or your kebab or it can be an ice cream also, accidental bite, it profusely bleeds. Now, এই যে ভ্যালেন্টাইন্স ডেতে একটা গোলাপ দিল, এবার অ্যাক্সিডেন্টলি একটা রোজ থর্ন প্রিক করে গেল তোমার আঙুলে, তো suddenly you suck or your partner sucks, because when you see cows and animals, there is an ulcer or a wound. They always lick, because there are some tongue and the mucous membrane, they secrete prostaglandins, and that is having some wound healing ingredients, helps in wound healing. বোঝা গেল? তো তাই জন্য চট করে আঙুল ঢুকে শাক করতে লাগলো বা লাগলে। Okay? Now, the lingual artery, pharyngeal part supplied by dorsal linguae branches, rest is supplied by arteria profunda lingually. Ascending palatine and tonsillar branches of facial artery, ascending pharyngeal artery. The arterial supply of the tongue can be a small question of 4 marks. Now venous drainage. Now venous drainage of tongue, superficial vein, drains the tip and the under surface of the tongue. The tip and the under surface of the superficial vein. Ends in the internal jugular vein. Deep vein drains dorsal of the tongue, this dorsal of the tongue, accompanying lingual artery, this is the lingual artery here, and drains into the dorsal of the tongue accompanying lingual artery, terminates in the internal jugular vein. This is the internal jugular vein. See, this is the under surface going to the jugular vein. This is accompanying the lingual artery and going into the jugular vein. Now, nerve supply. Somatomotor, all muscles supplied by hypoglossal nerve except palatoglossus. Now, somatomotor, all muscles supplied by hypoglossal nerve except palatoglossus. Okay, secretomotor, superior salivatory nucleus, preganglion fibers, submandibular ganglion, postganglionic fibers, lingual nerve, anterior lingual glands. Now, secretomotor, superior salivatory nucleus, preganglionic fibers, submandibular ganglion, postganglionic fibers, lingual nerve, anterior lingual glands. Now, vasomotor is from sympathetic nerve surrounding the lingual artery, postganglionic fibers from superior cervical ganglion. Sensory supply from anterior to third, general sense by lingual nerve, special sense by chorda tympani except vallate papillae, from posterior one-third, general and special sense by glossopharyngeal nerve, from vallicula, internal laryngeal nerve, interlaryngeal branch of the superior laryngeal nerve. This is very important. This now motor supply, somatomotor, secretomotor. Now vasomotor, so the sympathetic nerve surrounding the lingual artery, postganglionic fibers from superior cervical ganglion, sensory supply from anterior to third, general sense by lingual nerve, special sense by chorda tympani except vallate papillae, from posterior one-third, general and special sensory by glossopharyngeal nerve, from vallicula, internal laryngeal branch of the superior laryngeal nerve. Now, lymphatic drainage. See, in green, this is in green, these are the lymph nodes. See, these submental nodes, submandibular nodes, infrahyoid node, this is hyoid bone, infrahyoid, pre-laryngeal node, pretracheal node, anterior cervical node in suprasternal space. This is a jugulo-digastric node, upper deep cervical nodes, upper deep cervical node, this, the jugulo-digastric node, upper deep cervical nodes, jugulo-omohyoid, this is the omohyoid muscle. So, close to it is the jugulo-omohyoid node, and lower deep cervical, these are the lower deep cervical. Now, apical set of intramuscular and submucous plexus consists of the lymphatic drainage of tongue consists of intramuscular and submucous plexus. This is the intramuscular and the submucous plexus are there. Okay, drains tip and frenulum lingually, apical set. Some pairs mylohyoid drain into submental lymph nodes. This is submental lymph nodes, and drain into jugulo-digastric node, and this is jugulo-digastric node. Drain into the submandibular lymph nodes after piercing mylohyoid. This is the jugulo-omohyoid node, lower cervical nodes, and terminate into jugulo-digastric lymph nodes after passing deep to mylohyoid. Now, marginal set drains the sides of the tongue in front of the sulcus terminalis. Some vessels drain into submandibular lymph nodes. Some drain into jugular-digastric and jugular-humoid nodes. Now marginal set here, see submental node, submandibular node and infrahyoid node. Now central set drains dorsal surface of the anterior two-thirds of the tongue, anterior two-thirds of the tongue, this portion, and drains dorsal surface of the anterior two-thirds of the tongue in front of the vallate papillae, descends between two genioglossi, drains into jugular-digastric and humoid, drains into submandibular nodes. These are the different conditions of the tongue. This is also here. See, this is the tongue tie. It's a pendulum is tied here, shortened. So once you release this, once you release it, your tongue comes out.